Hello, everyone. Good evening, and welcome to the 15th and the final webinar in the NSTS webinar series. Thank you all so much for joining us tonight. Tonight's lecture is on paediatric surgery, as you can see from the title, and we're very lucky to have Mr. Séan O'Donnell here with us to lecture tonight. Before the lecture itself, just a few points from me. So for your peace of mind, everyone's cameras and microphones are automatically off and you can't turn them on. The lecture is being recorded and will be put on our website and YouTube channel probably tonight or tomorrow. Please put any questions that you've got in the Q&A box rather than the chat box, because we won't really be monitoring the chat box. And we'll go through as many questions as we got time for at the end. And a last thing is to please look out for the post-course questionnaire that we're using to evaluate the whole lecture series. And that's in our study called Educate. So links to that questionnaire will be going out on the mailing list very soon, and that will have all the information about participating and things like that. So just look out for that, and we'll really appreciate it if you can fill that out. So back to the lecture itself. So just to introduce Séan, so Séan studied medicine in Belfast after doing his gap year in a GP surgery in Wales and volunteering in Malawi. At the moment, he's a core surgical trainee in the Liverpool Children's Hospital, Alderhay, and he's recently passed his MRCS, so he's become a Mr. So big congratulations on that, Séan. And he's just about to apply to Paediatric Surgery Registrar jobs. So best of luck for that as well in the future. And most importantly, Séan supports Wales for the football, but Ireland for the rugby, which for those of you who watched last weekend will know is very fortunate. So without further ado, I'll hand over to Mr. O'Donnell.
Thank you very much, Lawrence. You can see my title slide there okay, and you can hear me okay?
Yeah, all good.
Awesome, so welcome to Paediatric Surgery, preparing for life as a surgical F1. So today I'm going to talk just a little bit about me and why I'm giving this lecture. What is paediatric surgery? It's not something we're exposed to very much in medical school. So I thought it's worth actually talking a bit about the subject. I'll talk through the roles of the department and what you actually do as an F1 in our kind of unit. And then trauma, something very significant in children. So I'll talk a little bit about that. And then common conditions. Whilst not much knowledge is expected of F1s, it's nice to know about some of the conditions that we deal with. Neonatal surgery is super interesting. So I'll just talk about that too. And then what's important both as an F1 and as a doctor in ped surgery or elsewhere. So firstly, thank you very much for the introduction, Lawrence. You've all basically, you know all this already. I'm from North Wales. After school, I had a gap year, did some GP work, well, in GP surgery, and then volunteered as a medical volunteer in Malawi, and that's my Malawi hat. Graduated from Queen's in Belfast. That's my dad. And then now I have a job in Alderhay Hospital as a core surgical trainee, which is the picture on the right. I did F1, F2 and a F3 sort of locum clinical fellow year, doing some pediatrics, medical and surgical jobs. Always thought I wanted to do surgery until I did pediatrics, and then I was really confused. I thought I might do peds instead, and then someone suggested to me, what about ped surgery? And since then, that's been my goal. That at the bottom is Alderhay Hospital, which is designed by kids and is a really fun place to work. Next for me is scary registrar applications later this month. Okay. Let me just fix this. Okay, so I thought I'd just tell you a bit about what surgery on children is. So we've got our first question. What century did paediatric surgery become a recognised specialty? What does everyone think? Is it a new specialty or an old specialty? When everyone's voted, we'll see what you guess. Ooh, it's a close one, but most people are actually correct. And the answer is the 1900s. So the story is that there was a ship explosion in 1917 up in North America, killed 2,000 people, 9,000 people were injured. There was a relief train, including Mr. William E. Ladd, the surgeon, who got very distressed at the poor care that the children were receiving. He slowly built up some data and procedural knowledge and began training junior surgeons on how to deal with children. He published the first textbook in 1941. At the similar time, the UK were starting to develop strategies to fix congenital abnormalities, and then anaesthetics slowly caught up afterwards. So where do we do paediatric surgery? Well, there are 26 paediatric surgical centres in the UK. 16 of those are training centres, so it's very specialised. If you think that's a lot of hospitals, there are over 1,200 hospitals in the UK. So yeah, really you can't have paed surgery everywhere. There are some elective lists done in district general hospitals, but often they need to be simpler cases and they need simpler care. So anaesthetics and where does the patient stay become part of the problems. Thinking about what we cover, it's not the same as adult general surgery. So it's probably easier to think about what we don't cover. So we don't really cover the head and neck, and we don't really cover the limbs, and we don't do cardiac surgery either, but everything else is pretty much fair game. There are specialist centres even within paed surgery for liver conditions or cardiac surgery. And then there are some super complex conditions like conjoined twins that need to be separated in Great Ormond Street Hospital. So we cover upper and lower GI, urology, thoracics, trauma and emergency surgery. We cover gynecology, although there isn't very much of that in children. We do a lot of vascular access, whether it's a PICC line or a tunnel central line. And we do some random things in other parts of the body too. And we help with other specialties who need to do operations on very small people. How do you get a job in this field? Well, the training pathway is from student placements and electives to trying to get a foundation job in a paed surgery centre. Then there's core surgical training after foundation. And you'd be lucky to get a paed surgical job sometimes in core training. I've been really lucky to be placed in Alder Hey. After that's registrar, that takes about 6 more years. So we're talking from start to finish a minimum of 10, but I don't think anyone's ever done it in 10 years. Often you need extra research, PhDs, MDs, so it does take quite a while to get to a consultancy. Even when you're a consultant, then you can specialise into certain areas of paediatric surgery, such as urology, neonatal, upper, lower GI, liver, things like that. And why would you come to this subject? Basically, it's clinically amazing. It's interesting. You get to examine lots of cute babies. You can appease stressed parents. You can fix pain in children. That's always good. You can make them smile, and you'll see things in this specialty that you just don't see in other ones. If you want more information about paed surgery, the Yorkshire and Humber Deanery website is where the ST3 applications are. They've got loads of info there about what they want from a paediatric surgeon, and then the British Association for Paediatric Surgeons as well. So roles of the team. So everyone is involved with chatting to relatives, documenting, being professional, being part of the team, and obviously playing with the children. The healthcare assistants and nurses tend to be the people doing observations and delivering the actual care itself. Physician associates are a new thing. They are great for clinical jobs. The F1s would be sort of similar kind of level, but less experienced. So they are really, there's not much expected of F1s. It's very senior led, really well supported, and decisions are always made from the top down in paed surgery. So that's very useful. And the advanced paediatric nurse practitioners and advanced neonatal nurse practitioners are invaluable. They're so experienced and they know so much about the subject of the department that they're placed in. It's great. The SHO is an old term, senior house officer, but basically it means anyone that's F2, F3, F4, locum, clinical fellow, CT1, CT2, ST1, ST2, Because all these jobs come under that kind of bracket. And their job is clerking in new patients, initial management, clinical jobs, operating. You get to assist with some operations, and you even get to do some operations when you're at my stage. I get to do a few things, and also some quality improvement. Regis are basically run the department, in my opinion. They're mainly involved with diagnosing, decision making. They do most of the operating, really difficult stuff with the consultants, or easier stuff they'll be training the juniors like me. And then the Regis and consultants are both involved with training. Consultants also the big operators. They do decision making, responsibility for the child lies with them, and they're involved with training and research too. Trauma. So I'm aware that you had an orthopedic lecture yesterday, I think. It doesn't really involve F1s too much when brand new traumas come into hospital. F2s would be involved though. And F1s we would encourage to come to a trauma call if available. It's quite similar to adult trauma in the way it's run, but the injuries are different, and children present differently with trauma too. But whenever they first come in, it needs to be a major hemorrhage, cervical spine, and airway all assessed immediately. And then after that, breathing, circulation, disability, and everything else, including exposure. So I'm not going to labour through the ABCDE points. The people involved with the trauma team, you need some admin staff to put the patient on the system so they can get their drugs and scans. You need the A&E team to run the trauma and maybe do the initial assessment. Anaesthetics should be present, especially if intubation is needed. Surgeons will be present for any procedures that need to be done. Orthopedics will be present. Radiographers to do the scanning, radiologists to interpret the scanning. They won't necessarily be at the trauma, but they certainly need to be available and made aware. It's a team, same. They won't be there necessarily, but they need to be aware, especially if this patient is going to be needing an operation ASAP. Paediatric intensive care unit depends on the trauma, but that's probably where the patient is going to go next. So they need to be alerted early. There's always a scribe at traumas too. That's someone in the corner basically writing down absolutely everything that's happening, who's there, who's doing what, and what time everything's happening at. Our job as surgeons that turn up to a trauma call, we're often involved with examining, cannulating as well. Arterial blood gases, we don't often do them, but we might need to do a femoral stab, immobilizing or mobilizing the patient. And then if there's a pneumothorax, maybe a thoracocentesis, or if there's a hemothorax or a large pneumothorax, you might need a chest drain inserted, We might also be involved with a surgical airway. So that can be a needle or an open cricothyroidotomy, and that is the last resort for a real big airway obstruction. It's not the same as a tracheotomy, which is an elective procedure. Electively, we try not to use radiation on children too much because it's the risk of lifetime cancer is a lot higher in kids, even with low dose CT scans. But with a trauma, it's a bit different. You need to find bleeding ASAP. So we do a CT trauma series, and that'll be head, neck, chest, abdomen, and pelvis, and then X-rays of anything else that needs it. We might need to operate on a trauma, so that operation would be usually an emergency laparotomy for anything inside the tummy that we think is wrong, or an emergency thoracotomy for anything inside the chest we think is wrong. The sternotomies are pretty rare, so we don't really do those. The primary survey is when they first come in. Secondary survey is a bit later, once they've had a bit of resuscitation. And then the tertiary survey must be done before a patient goes home. And that's usually a head to toe. The F1s will be involved with this. That's usually a head to toe of every single joint, bone, and system of the body, proper history and a collateral history too, and then any extra scans or bloods that need to be done to make sure nothing has been missed. So I want to talk about some common conditions we see now in our paediatric surgical unit. And there's an awful lot of elective surgeries. That will be most of the operating. Any operation might need to be done on any part of the body. From an ingrowing toenail, we do gastrostomies, bladder injections and stents, foreskin operations like circumcisions, hernia repairs, and I think our most common operation is orchidopexies for undescended testicles. Lots of emergencies too. We get basically anything with abdo pain, usually appendicitis, but also things like intussusception, malrotation with volvulus, neonatal obstruction too, which can be a lot of rare conditions, but meconium ileus and atresia, might have heard of those, and Hirschsprung's disease. They're common presentations of neonates with bowel obstruction that need emergency surgery. We'll talk a bit about groin lumps as well, as that can be very scary for parents and children. And we'll definitely talk about torsion. You can never miss a torsion, so we often end up exploring lots of scrotums to look for torsion, and sometimes they're not torted, and that's okay, because we really don't want to miss one. I'll briefly talk about limping children as well, which can be something or it can be nothing. It doesn't usually come under the paediatric surgical team, usually orthopedics, but it's useful to learn about. And then congenital problems. These kids can be really complex, really difficult to assess. So luckily, it's the seniors that make the decisions, and they can interpret these kind of tricky customers and get to the bottom of what's happening. So appendicitis, you've all done it to death. I'm sure. I think you've even done it in a couple of these specialty lectures. But appendicitis, I thought it's very important to know about. So it's the most common surgical emergency in the whole UK. Your appendix is 5 centimeters long at the end of your cecum. Its function is completely unknown, hypothesized in the past. We don't really know why appendicitis happens, but it's assumed to be caused by a fecalith, a bit of poo stuck in the appendix. There's a complete blockage so that beyond that fecalith can't escape, and that bacteria turns into pus, stretches the appendix, and damages the blood supply to it as well. So that's what's thought to be the cause. In children, it presents a bit differently to adults, as I mentioned. So that's McBurney's point in that picture, 2/3 of the way from the umbilicus to the acis. So if a child says, if you say, where's the pain, and they point with one finger straight down on McBurney's point, then you're in luck. But that's pretty rare, actually. So that's less important, because basically the appendix can be in lots of different positions. It can be inflamed and like very vague symptoms. So a retrocecal appendix, for example, might not have any kind of anterior wall pain whatsoever. And a pelvic appendicitis might present with loose stools and diarrhea as the rectum is touching the pelvic appendix. So it's very tricky. They might present with parents saying things like, oh, he's just not right. He's got tummy pain. Oh, he's vomited. I don't know why. He's not eating well. But on examination, you might get some peritonism. Yeah, and that can be related to the position, as I mentioned, or the severity. When examining these patients, you always need to examine the testicles too, if they're a boy, as you can never, sometimes a torsion can present with abdominal pain. They always need a really good set of investigations done. So every child that comes in with tummy pain needs a urinalysis. All girls need pregnancy test too. We need to get some bloods, so a capillary or a venous blood gas to look for lactate and CO2, really important. That's a good indication of electrolyte levels too. It's important to get an FBC, a UNE, and a CRP, pretty standard. And then any tummy pain really should be, you should get a liver function test, amylase, and a bone profile as well to look for hypercalcemia, can present with abdomen pain. Kids with query appendicitis will most likely get an ultrasound scan too. Our ultrasonographers are much better than adult ones in my opinion. I can find the appendix really quite easily, especially if it's inflamed. But that's often due to kids being a lot smaller and less fat than adults too. So what do we do for appendicitis? Well, we might give conservative treatment with just some antibiotics, some fluids, some supportive care, keep examining them, making sure they're okay. We did that a lot more during the COVID first wave. Interventional management. So sometimes we might need to put a drain in. So if they've got an appendix mass or a phlegmon, an abscess, they might need a drain. That might be better than an operation for some kids. And then obviously operations is what we've all heard of. The operation we tend to do is keyhole surgery, laparoscopic. We have 3 ports, one in the umbilicus and then 2 others. The camera goes in the umbilicus and then 2 other ones for your instruments. Sometimes we need an extra port, sometimes we need to open it. If you do an open appendicectomy scar, you should always remove the appendix, even if it's normal, because it looks like the patient's had an appendicectomy when they have that scar. During the operation as well, we'll also consent them for a PICC line or a long line, and that's because cannulating children is a bit tricky because they usually don't want to be cannulated. So if they have one rubbish cannula and it's pulled out 2 hours after surgery, you're a bit stuck. So what we tend to do is when they're asleep, we put a long line in if we think they're going to need a few days of antibiotics or fluids. Or some kids have very severe appendicitis and might have a long ileus and might need TPN, in which case definitely best to do that whilst they're asleep. The appendix looks normal. As I mentioned, if we do an open one, we still remove the appendix, but it's important to look for other causes for the tummy pain whilst they're inside. So it could be microscopically inflamed and it'll still look normal. So removing it isn't a problem. Some people do, some people don't. They might have a Meckel's diverticulum. So that's the blood supply for the appendix there. This is a Meckel's diverticulum. You've probably heard of this. So you should always look for a Meckel's if you see a normal appendix. And you might know the rule of twos for Meckel's diverticulum. So it's 2 inches long. It affects 2% of the population. It is 2 feet from the ileocecal valve. It affects males twice as often. It usually presents less than 2 years old. And it has 2 types of mucosa, mucosal lining on the inside, which is why sometimes it bleeds. So that's the Meckel's rule of twos. So look for a Meckel's. It is an embryological remnant of the vitellointestinal duct, by the way. So some people have it, and 2% of the population have it. So some people watching this lecture might actually have it. Other things to look for when you're inside, if you see a normal appendix, Crohn's disease, terminal ileitis, and if it's a girl, look at the ovaries. They might have ovarian cysts, endometriosis, ovarian torsion, pelvic inflammatory disease. You need to spot these things if you're inside. Lots of complications of appendicectomy, unfortunately. You could have a very sick child afterwards with ongoing abdominal collections. They might need drainage, wound infections. You could get hospital-acquired pneumonia by not moving very much, urinary tract infections, especially if catheterized. And then it's worth always talking the parents and the child through the fact they might have a long admission, they might be in a bit of pain after the procedure, and they might get adhesions, which cause pain or obstruction in the future. So it's tricky in kids, appendicitis. So here's the next question. What does everyone think your lifetime risk of appendicitis is? Is it common or uncommon? So people think it's common. Most people are going for the 10 to 20% range there, but a lot of people guessing the other ones too. And the answer is 5 to 10%. So 8.6% lifetime risk for men and 6.7% lifetime risk for women. And I don't know why it's a slightly higher risk for men, but I'm determined to look that up in great depth at some point. So it is a very common condition. 5 to 10% of the whole population get this at some point in their life. That's a very, very important disease for our population. Groin lumps. So I've put these in order of most common to least common. Basically, if a child presents with a groin lump, have a really good investigation. It could be lymph nodes. If so, make sure you examine lymph nodes elsewhere. That can be reactive due to localized infection or distant infection or inflammation, but it could also be the presentation of lymphoma. So really worth investigating sometimes. Hernias, boys are a bit more likely to get them than girls. And if you've had one on one side, you're more likely to get one on the other side. In kids, hernias, inguinal hernias anyway, are usually indirect. So they come right through the deep ring and come out the superficial ring of the inguinal canal. Whereas in adults, they're usually direct hernias. And they're quite closely related to hydroceles, patent processus vaginalis. So when the testicle descends embryologically through the inguinal canal into the scrotum, then sometimes it leaves a hole behind it. If the hole is massive, then that can be a hernia. If the hole is very, very small, but still let some fluid through, then it can cause a hydrocele. Hydroceles transilluminate really, really well, and the testicle should usually be felt separately. If you can't feel the testicle separately with a hydrocele, you should get an ultrasound to make sure A, it's there, and B, that it doesn't have a lesion or a cancer on it, and that the hydrocele isn't reactive. It sounds a bit silly, but a groin lump could be a testicle. So you can get many places for ectopic testes or undescended testicles, but sometimes when babies are born, they get baby checks, and not all the testicles are down. They usually come down eventually, or they need an orchidopexy to bring them down. But sometimes people can't add 2 and 2, and they have a groin lump and no testicle in the scrotum, and it's the testicle. Varicoceles can be traumatic or completely idiopathic. Basically a collection of blood vessels that are swollen. Varicoceles are clinically very important if it's on the left, due to the venous drainage of the left gonadal vein, which drains into the left renal vein. Sometimes a left renal mass can present with a left varicocele. So that's not the same for the right. So all left varicoceles need to have ultrasound testicle and ultrasound renal tracts as well, just to look for a cancer or something. Traumas, we get lots of trauma to the scrotum. It's usually accidental, but worth taking a full history and examining, and then reassuring the family they probably need some rest and pain relief. Cancers can unfortunately present in kids, so it's always worth thinking about that, examining the testicles properly and making sure you do any imaging or get blood tests or cancer markers if you need to. And then there are really rare congenital or acquired lymphatic malformations as well, which they need really a lot of investigation, and they're usually associated with other genetic conditions. So I'll now talk about torsion. It's a big thing, everyone knows about it, and you can never miss it, because if you tort a testicle, it can lose its blood supply, you can lose the testicle, and a man can become infertile, especially if it happens on both sides, or if a man only has one testicle. It's also important to talk about the ovaries, but I'll talk about the testes first. So it tends to present with abdominal or scrotal pain, swelling, redness, heat. They usually vomit. The child might be embarrassed, might not want his parent to see his testicle. So it's always worth, really making sure you make a rule, every abdo pain, look at the testicles. And then on examination, the tummy is usually soft and doesn't have any problems. The testicle is extremely tender, like really, really sore. It often sits a bit higher, as you can see there with the torsion. It's twisted, it's lying flat, and the vessels that it's hanging off are twisted, so it just becomes a bit shorter. The cremasteric reflex is often absent, but not necessarily always. And then there's no blue dot. The blue dot sign is associated with a torted hydatid of Morgagni. We do urine investigations just to look for something else, particularly important with adults. There's no need for blood tests or ultrasounds or any kind of scan, because they might delay going to theatre. If you're really worried about torsion, they need an exploration. They need someone to lay eyes on that testicle. Saying that, if there is no delay to theatre by doing an ultrasound scan, then you should definitely do it to check perfusion to the testicle. So the top differentials for a scrotal swelling would be a torted testicle, a torted hydatid, very common in kids. The torsion of the testicle usually is in a teenage boy, and a hydatid is usually a bit younger. A hydatid is just, it's kind of the appendix of the testicle. It's an embryological remnant. That's all I'll say about that. Kids can get epididymoorchitis, but it's less common. In adults, that's a much more likely differential, especially as STIs are so prevalent. We've already mentioned varicoceles, hydroceles, and appendicitis can present with testicular pain, but not necessarily swelling. And then cancers can present with testicular pain, but rarely. Management of these, if you're very confident it's not a testicular torsion, you can send the patient home with reassurance, possibly with antibiotics if you really do think this is epididymoorchitis, if they're sexually active maybe. But if you're unsure, you've got to explore, is the take-home message. So we do an awful lot of scrotal explorations looking for torsion, and we don't actually have very many. It's quite a simple operation. You go through the layers of the scrotum. You visualize the testicle. If it's normal, you just close it back up. You remove the hydatid if that's what is twisted, which doesn't do anything. And then you close up and then the operation's done. You don't need to look at the other testicle. Let me just move on here. I'll show you what a torted testicle looks like. There you go. So this one has a right testicular torsion clinically, and this particular testicle was not viable in the operation. So they had to do an orchidectomy. So this next one is in the middle of the operation. So if you go in and you find a torted testicle, then you bring it out, and that's the torted one there on their left testicle. So this was torted. They bring it out, have a look at it, and it needs to now be wrapped in a warm saline swab and to see if it reperfuses. Then, because you know that they are at risk of torsion, the other one needs to be brought out, and you need to decide that one needs to be stitched back in place with 3-point fixation. And then you have another look at this left testicle, say, is it viable? And I think actually this one probably is. Look, there's a bit of pink there. So I think you might give that one the benefit of the doubt and put it back inside and see if it survives. You stitch them both back up and make sure they can never twist ever again. So we talked about, I didn't really talk about bell clappers phenomenon, but that was that's this picture here. So basically it's a congenital problem with your tunica vaginalis that makes you more likely to have a testicular torsion. If you go in and find no torsion but see bell clappers, then you should basically fix both testicles in place as well. Ovaries next. So girls can present with vague abdominal, non-specific pain. Sometimes torsion isn't the top thing you think of. It's usually, if it's in the right side, you might think appendicitis more. So they need to be investigated as such. They get, they might be vomiting and they might have a mass as well. It's worth noting, but they're usually in an awful lot of pain. These girls will definitely need a urinalysis. They'll need a pregnancy test. They need blood tests as per usual abdominal bloods, and they definitely need an ultrasound. But if there's a delay to get into theatre and you really think this is a torsion, and you can't get an ultrasound in the middle of the night, for example, then go ahead and do a laparoscopy. So on laparoscopy, this is what a torsion looks like. So you've put a camera in, you've had a look, and there you go. There's the vessels to the ovary. So it usually happens with an ovarian cyst. You can see how heavy that cyst is, and you can see this precarious axis that it's on. So you can see how that is going to twist. So nearly all torsions are related to large ovarian cysts, in which case you might need to do an oophorectomy if it's not viable, but we don't know how black that is underneath the tunica there. So yeah, it's hard. You have to explore and untwist it and see if it looks viable. Limping child, as I said, they don't come under paediatric surgery, but it's worth mentioning. Tummy pain comes in under us, and actually tummy pain can sometimes be a hip problem. So trauma can affect any child of any age. You've got to think about any accidental injury. They're very injury prone kids, especially toddlers have just learned to walk and talk. But you've also got to think about non-accidental injury. So if you ever think of NAI, always escalate. If it even crosses your mind, escalate and get someone senior to make that decision. If something just doesn't fit, if the history isn't quite right, or if there's signs of other injuries or social circumstance, then just get a senior. Developmental dysplasia of the hip, basically the joint doesn't fit properly. It presents in babies, so they haven't walked yet, they don't present in pain, and they need a harness. There you go, a Pavlik harness like that, or a short leg hip speaker cast, and then they tend to heal by themselves. Risk factors to having DDH are being breech when you're born, being female, being the firstborn, or having a family history as such. And the way to detect it is in the baby check. All babies get Ortolani's and Barlow's hip exams. You'll feel a click. I've only felt 2 clicks ever. I've probably done over 100 baby checks. So reactive arthritis, also known as transient synovitis, is usually related. So it's usually in kids 1 to 5 years old. So toddlers, they often have a mild injury or an illness elsewhere. They might have a temperature, and it's completely self-limiting. It's just reactive. So if you've diagnosed this, you need to reassure parents, suggest some pain relief and conservative management, and then make sure that they know that it can come back if things don't get better. Perthes disease of the hip. So usually in slightly older kids, 5 to 10 years old-ish, And this is avascular necrosis of the femoral head. Usually affects boys, can be very serious and needs referral. So young teenagers can get SUFI. It's usually obese teenagers, often boys. You get some leg shortening with this sometimes, and you get knee pain. So let me just show you what an X-ray of SUFI looks like. So you've probably looked at fractured neck of femurs before. It's not quite the same, but you can see Shenton's lines here. So this is Shenton's line. It looks perfect on the right, and on the left, Shenton's line is it kind of goes nowhere here. It doesn't really link up properly. So you would look for fractures if this was an adult, but in a kid, you can see there that his epiphysis has just slipped off his actual neck of femur. Inflammatory arthritis, you get juvenile idiopathic arthritis at any age of kids. It's the most common childhood arthritis. It affects various joints, can be various severities. It needs NSAIDs like Brufen and a referral to rheumatology. And then infectious arthritis is an emergency. Child might be septic. So if there's a single joint that's red hot and swollen, get it referred, treat that patient ASAP, admit them. They might need aspiration or joint washout as well. Get the orthopedic team involved. So congenital and genetic problems are really complicated, but I think they're super interesting. There are basically as many problems as there are developmental pathways in the body. So there could be anything wrong really with a baby when they're born. The first thing there is atresias, so being born without something really fully growing. That's usually, when it comes under our team, that affects any part of the bowel from the esophagus really to the anus. Anything can not grow properly. Tracheoesophageal fistulas are really interesting. These are the 5 main types. So it's any kind of link between the esophagus and the trachea. So you can see here, these babies are not going to survive or grow without a procedure. Even in this middle type here, which is a bit less common, the baby still can't feed. If they feed, they're really at risk of aspiration and milk going into the lungs. So they're not very well. They need procedures usually on the 1st or 2nd day of life to fix this. And then they need to be fed either with a PEG, a gastrostomy, or maybe a really long NG or NJ tube. We sometimes call that a TAT tube if we've done an anastomosis of the esophagus. So tracheoesophageal fistulas are associated with VACTERL. You might have heard about this. That's vertebral, anorectal, cardiac problems like tetralogy fallow. And we've mentioned tracheoesophageal fistulas and esophageal atresia too, and renal problems, limb problems. These are all often go together in a single VACTERL anomaly, we call it. Meconium ileus is heavily associated with cystic fibrosis. So of all of the babies with meconium ileus, 90% of them have got CF. And of all of the children with CF, less than 20% have ever had a meconium ileus. Cloaca, you might have heard the term before, it affects vertebrates, commonly birds. They actually have a cloaca. It's abnormal in babies though, obviously. It's a single posterior orifice for reproductive, urinary and digestive tracts. Anorectal malformations and Hirschsprung's disease. So Hirschsprung's is basically having aganglionic bowel, usually affects the rectum. And this means that the bowel can't squeeze, the muscles don't work, so you get very dilated bowel and obstruction. And these children usually need stomas before they can have that repaired. Anorectal malformations covers a whole array of things, but again, the baby usually needs an operation and stoma until things can be sorted out down below. It's much easier to let these babies have a stoma, grow, and then we can do further operations when they're much, much bigger, a few months or even a year down the line. Posterior urethral valves basically means that there's no way out for urine from the bladder. So this needs urgent intervention to get that urine out because your kidneys still make urine. So if a baby is born, they will need nephrostomies inserted straight away or a vesicostomy. But you can actually cure some of these things antenatally too. So I met a baby last year who, when they were 19 weeks gestation, they got a vesico-amniotic shunt inserted, and then they weren't born for another 20 weeks or so. So their bladder was able to directly drain into the amniotic sac. It was really cool. And that baby did really well, actually. I happen to know he's alive and well. and genetics. So I'll just touch on genetics because it's super complicated. Massive specialty. They run a lot of antenatal clinics that the surgeons can get involved with to tell parents what to expect if the baby's viable, not viable, if they need operations when they're born, etc. And they often need lots of parent and sibling blood samples, things like that. This is just a doll, by the way, so you can help explain to parents what to expect and what a stoma is and how it looks on a baby. Because it's very normal for us, but obviously it's very scary for parents. Here's the next question. So what do you think is the most common part of the body to not form embryologically? Or in utero, I should say. So people have gone for esophageal, which is probably the one you've heard of the most, and duodenal next. So duodenal atresia is really linked to trisomy 21. There's a huge association there. So that's maybe why you've heard of it. Not many people went for jejunal, interestingly, which is the answer. So between 1 in 1,000 and 1 in 3,000 live births have not got part of their jejunum or ileum. So that's you know, it's relatively common actually. The least common of those there is pyloric atresia, which is 1 in a million. I've never even seen it before. So neonatal surgery, I'll just briefly touch on this. Again, doesn't really affect the F1s too much on our wards, but these are still our patients on our list, and you might be asked to do jobs for them. So prematurity, even of a healthy premature baby, is heavily associated with necrotizing enterocolitis, just where the bowel gets infected. It's not ready yet to deal with being alive, being born. So this is what neck looks like on an X-ray. You're not supposed to be able to interpret this as F1, but I don't know if you can see in the bowel wall, especially over here, there's kind of a bit of extra air there. That's called pneumatosis coli. You can see it throughout, really, at the bowel wall. That's neck, NEC. So that needs treated with bowel rest and then TPN and conservative management with a long course of antibiotics. Sometimes it can get worse and it proceeds and perforates. And this unfortunately is a perforation here. So you can see this is an unwell baby. They've got some tubes. You don't have tubes if you're a well baby. And you can see a bit of free air there, a bit of free air here. And then the lateral view is even better. That's the liver, and above the liver, when the baby's lying down, that's free air. So that's perforated from the bowel. This baby needs an operation. They'll be lucky if they get an anastomosis, but they might need a stoma, most likely. Neonates are really hard to look after. They're tiny. They can't grow well. They can't look after their temperature well. They don't heal very easily. And they're tricky to feed, especially if we've done bowel surgery. So then they might need TPN to get bigger and to gain weight, in which case that has its own full set of problems. The families of these children need a lot of support, and Alder Hey Hospital is really good for that. Really good unit. So I thought I'd do a couple of cases for everyone. I'm aware time's taken on, so I'll keep going through as fast as I can. Okay, so this is a 12-year-old girl. She's overweight and she's not feeling right. She's had some abdo pain. She's had this pain before, but this pain's been present for the last 20 hours or so. So if the girl's in pain, you need to do a full history of presenting complaint, and then a focused history, and then we need to do Socrates as well for pain to find out more about it. We also need to get a full background of this patient. So for all we know, at this point, the patient might have had 12 operations before. So we need to ask a proper medical history and ask a surgical history separately. People forget they've had operations if it's not relevant to the current condition, if it's not an ongoing medical problem, such as tonsillitis. You know, it's quite useful to know they've had an anaesthetic before. Family history, much more important to ask that in any child than it is an adult, as it's, you know, they're much younger. They might have a lot of diseases of childhood that run in the family, for example. You need to know a drug history, allergy history, social history, really important for children. You need to know if there's a social worker involved. You need to know if they're on the child protection register. If they're a girl, get a gynae history, 12 and over, ask gynae history, or any girl that has periods. And then you need to start going through systems. So it's important to ask about any weight change, any infective contacts, recent travel, dodgy foods, coronavirus, COVID contacts. COVID often presents with abdomen pain in children. It's a bit different to adults as well in that respect. Always ask about bowels, urine, and appetite too. So this girl has had a period 2 weeks ago. She's not hungry, but she's snacking and she's mobile, and everything else was negative. So she's nothing, no history of note. So we want to investigate this girl's pain. So we want to do abdominal bloods, FBCU and CRP, LFT, amylase, bone profile to look at that calcium again, urinalysis, and she's a girl, she needs a pregnancy test. The urine, so here you go. The white cells are 14, which can be normal for a 12-year-old. Neutrophils are 11. Again, it's a bit high, but it's okay. CRP is 20, now that's a bit abnormally high. It should be less than 4, but again, it's not very high. The urine's got some leukocytes in it, so white cells. So that could be relevant. It's only got 1+ of those and nothing else, so there's no nitrates. So it could be urine infection. It could be something else. Temperature is low grade, 37.6. Heart rate 130. That would make you panic in an adult, but that is normal for a 10 to 15-year-old. 100 to 150, it's really changeable on the child's age and weight. Blood pressure looks a bit low, but that's normal for her age. Resps are normal, SATs are normal. So on examination, she's got some lower abdominal pain. It's worse on the right side. CAT refill time is 3 seconds. That's just the upper limit of normal for a child. Her ENT exam is normal. There's nothing focal in the abdomen. There's no rashes, bruises, scars, masses, or hernias. It's important to always do ENT exam, especially if you're thinking about mesenteric adenitis, and also do a lymph node exam. So check your cervical lymph nodes, inguinal lymph nodes, very important. So your senior has already seen this patient earlier in the day, and they have decided to admit them for observation and an ultrasound scan in the morning. They haven't got around to prescribing any medications or fluids just yet. So this patient, what do you think is going on with them? Next question. What do people think? Ooh, people think Mittelschmerz, okay. So Mittelschmerz is usually a ruptured ovarian cyst of sorts, ovarian torsion, could be mesenteric adenitis. So the answer is any of them. All 5 of these conditions can easily present with exactly these OBS and these numbers, this presentation. Very vague abdominal pain. And a very sensible plan is to admit this patient for another examination for an ultrasound. It could end up being nothing. You could diagnose nothing and they could go home the next morning. But that's safe to do that. Equally saying, it could have equally just been as safe to send this patient home with some reassurance to come back if things get worse. So the safer option is definitely to admit though if you're unsure. So let's keep going and see what happens with her. It's now 6 p.m. and the child has vomited. She's in more pain and the nurse says she's just not right. Her OBS now, heart rate's a bit up there at 180. She's tachycardic. Blood pressure's still fine. Resps are a bit higher, but still in the normal range for a 12-year-old. SATs are normal, and temperature's gone up there to 38.1, a mild temperature. So what do you do for this patient? And the answer, as always, A, B, C, D, E. Start from the top. And you want to do a proper examination. When you get to E, I want you to examine the abdomen properly. What do you find? So the chest is clear, heart sounds normal, there's no rashes, and the pain in the tummy is definitely worse. She points to the right iliac fossa, and there's peritonism now on examination. So how do you manage the patient? I've already shown you, but if you're worried that someone's septic, then sepsis 6 is always your friend. So you want to put oxygen on, give them fluids. If they're tachycardic like she is, maybe they need a fluid bolus, a blood gas, usually a capillary gas or a venous gas. We don't do ABGs often in children. Measuring urine output, sometimes it's a bit mean to put a catheter in a child. They'll not tolerate it or not enjoy it. So you can just ask either the child or the parents to measure the urine output. So in babies, we can sometimes do that by measuring nappy weights. And other kids, they can just pee in a bottle or a cup or a dish or something. but if they're very unwell, I would definitely catheterize. We need to culture this child, so blood cultures, urine culture anything, do a COVID swab. And then antibiotics is a tricky one. So in an adult, you'd throw them in straight away, but in kids, because we haven't diagnosed the condition yet of appendicitis, you might be best off holding off, because if you treat the appendicitis partially with an antibiotic and then they're examined by a senior later on, then the examination findings won't be the same, and it may really mask the diagnosis. So I would always phone a senior before giving antibiotics to a query appendicitis. And you want to phone your senior and you want to say, do you want a chest x-ray as a part of the septic screen? Do you want an ECG? Do you want an ABG? And do you want antibiotics? And they'll usually come and see the patient. So then your senior has arrived and they have confirmed your suspicions of appendicitis, booked the patient into theatre, they've contacted the anaesthetic team, they've consented the patient for a laparoscopic plus or minus open appendicectomy plus or minus a long line or a PICC line. A long line just means a cannula that's much longer, really hard to pull out. A PICC obviously is a central line that goes to almost the right atrium, usually the SVC. So it sounds a bit scary managing a patient like this, but it's not. So your job is really to see and to treat immediately and to escalate. So fluids scare people and medications scare people. One thing I would say about prescribing for kids is that use your BNF. BNF for children is my Bible. I use it every day. There's a great app for it. So it just tells you everything is by weight for kids. Especially fluids as well. So a bolus of fluid is normal saline, 0.9%, and we give 10 mils per kilogram as a bolus, or a bigger bolus would be 20 mils per kilogram. After the bolus, they'll usually need a bit of maintenance fluid. So that's depending on their weight again. So a child less than 10 kilos, for every one of the first 10 kilos, they get 4 mils per kilogram per hour of maintenance. The next 10 kilos of their weight, they will get 2 mils per kilogram per hour for each of those kilograms. And then for every kilogram over 20, they'll get 1 mil per kilogram. So as an example, a 5 kilogram child will get 4 mils per kilogram. So that's 20 mils per hour. 15 kilogram child will get 4 mils per kilogram for the first 10 kilos, so that's 40. And then for the next 5 kilos, because they're between 10 and 15, that'll be 2 mils per kilogram. So 2 5s is 10, 10 plus the 40, so 50 mils per hour. Sounds complicated, but once you've done it 2 or 3 times, it actually becomes second nature. You can work them out daily as well as instead of hourly. Instead of using 4-2-1, you can use the 150-20 rule, but it's almost the exact same maths. One thing to note about maintenance fluid for kids is that they always need to contain glucose. They always need dextrose inside the bag, 5%. Kids are much more susceptible to hypoglycemia, especially if you fill them full of fluids. If you're ever in doubt about prescribing something for a child, then just ask. Neonates don't quite fall into this, by the way. They have a slightly different regime. They tend to start their daily maintenance requirement really, really low, like 60 or 70 mils, depends on their gestation. And they build up to a really high 150 mils per kilogram per day sometimes. So the diagnosis in this particular case was appendicitis, but it really could have been any of those. And this is our most common diagnosis in kids with tummy pain. I used to work in A&E for children in Belfast, and honestly, the amount of kids that didn't have a cause for their tummy pain and just got better was very common. So time often tells you the answer and further investigation. So the next case is a 14-year-old boy. He's got tummy pain. He's had it for 8 hours. He's with his mum and he's a bit embarrassed. The pain's getting worse and he's vomited once. He's got no past medical history, family history. I've mentioned gynae history there, but he's a boy, so I think that's a mistake. And there's no allergies for this boy as well. Again, you need to ask about all systems, appetite, bowels, urine, everything that we mentioned before. So he's, investigation-wise, he's had a urine sample, dipped. The urinalysis shows nothing. but the bloods aren't done yet, and there's no scans done yet either. So what's his observations doing? His temperature is fine, heart rate, it's a bit high for a 14-year-old, just a bit, so you need to get your Pew's chart out again to work out if this is high or not. Normal blood pressure for his age, that's normal, and that's normal too. So on examination, he's got lower abdominal pain. It's a bit worse on the right side than the left side. His capillary refill time is 2 seconds. He's had an ENT examination. You've done that and you find it normal. His chest is clear. His heart sounds are normal. His pain is definitely on the right side. It's not very focal though. There's no peritonism. He's got no rashes, no bruises, scars, masses, or hernias again. And his lymph node exam is normal too. So there's one thing I haven't mentioned that we've examined there. Really important for any boy with tummy pain, and that is testicles. So mum steps out of the room, the chaperone comes in, and then you get him to put his trousers down, and then the right testicle is swollen, it's hot, it's red, and it's really, really painful to touch. There's no cremaster reflex that you can elicit, but he's also very nervous, and you can't see a blue dot. So what is the assumed diagnosis for this child? Good. Nearly everyone got that right. And yes, this is absolutely a testicular torsion until proven otherwise. And the people that said torsional hydatid, I mean, it could be, definitely. But the worrying thing is this a twisted testicle? Is this child going to lose this testicle? He's had an 8-hour history. So whilst ischemia really sets in after 6 hours, this is a child you would want to explore in theatre. So what are you going to do if you see this patient? You make them nil by mouth. If they're going to have an operation, you need them to not eat or drink anything. Just in case they're getting an anaesthetic, you don't want them to aspirate. But it is an emergency, so they need to be seen by a senior ASAP. If your senior is in theatre, then you would interrupt them. Phone the consultant on call, phone anyone. They need to be booked as a category 1, which means done ASAP. And the anaesthetist needs to be alerted, they need consented, they need IV access as well. So just my last couple of slides now. In paediatric surgery, we're all about patient and parent-centered care. Patient is the most important person. Beware of the worried mother. Not to be sexist, but it applies to dads, grandparents, and carers too, but we mainly see kids come in with their mums. And they're worried for a reason, so explore that reason and reassure them if possible. But mums often know if their kid isn't right, and they'll have they put up with a lot at home. So for a mum to present with their child, sometimes that means that they're really worried. We have a very low threshold to admit whether we're worried a bit about the child or worried that the parent is very stressed and requires admission for a period of observation, and that's completely fine. And if we do send them home, we give them a good safety net. They know where we are, so they can come back. One thing I would say is empathize. You know, this child is very stressed and scared, especially with us nowadays. We all wear masks and goggles every time we see anyone. Some kids seem to like that, I suppose. So empathize with the child, empathize with the parents. They're usually very stressed. To have a child go through an operation, be asleep and out of your care is really, really stressful. For a newborn baby, whether they're the sickest child in the hospital, I think it's important to congratulate the parents on the birth of their new child. They've been through the pregnancy, the whole antenatal process. You know, they're worried to death, and they are really proud and excited to have their child, even if they're very unwell. So congratulating on new babies is important. Speaking of which, get the gender of the baby correct. I've definitely done that wrong a few times. I've even called it a boy or girl after I've examined the boy and seen his willy. So just try your best to get the right gender, the right sex, I should say. Yeah, so that's really the main focuses of our ped surgery job. I think that's an F1 to be successful. If you're enthusiastic, you'll be much happier in work. Organized, I think it's really important. You get the most out of your job if you try and stay organized, try and stay on top of things, turn up on time, keep lists, hand over everything that needs to be handed over, do your jobs in the order they should be done in. and then keep the nurses on your team. So teamwork is really important. The nurses are your friends. Your other F1 colleagues can be leaned on, really important. And your seniors as well. You know, you get really good working relationships with some people. That's me there on my first set of nights as an F1. Me and one of my best mates were on nights together, and we were really proud that we actually took a photo. It's a bit corny, I know. Communication is implicit for patient safety. So especially when it comes to handovers, escalating to seniors, and talking to colleagues does get a lot easier the longer you stay, the longer you work, basically. I think a healthy doctor makes a healthy patient. So psychological well-being, make sure you exercise, have a balanced diet, keep your stress levels low if you can, and rely on family and friends. That's what they're for. So make sure you stay in contact with people. Do what makes you happy outside of work too. It makes you much better in work. So thank you very much for listening, everyone. Really appreciate it. If you have any feedback, there's the QR code. Sorry, I went on a bit long. I'm not sure, just about right. If you've got any more questions, my email's at the bottom. Thank you.
Okay, thank you so much, Sean. That was a fantastic lecture and some very great words of wisdom there at the end as well, just general advice. So yeah, guys, just take 30 seconds, please, to just fill out that feedback on the QR code. The feedback link should be put in the chat as well. That should be coming up there in soon. And feedback links will also be on the emails that we send out with the recording. So we'll just go through a few questions as we are slightly, yeah, feedback links in the chat now, guys. We'll just go through a few questions at the moment. Oh, if I can get rid of the chats in a way. Okay, so are there any tips for aspiring pediatric surgeons on how to build a good portfolio and get opportunities to access pediatric surgery? Maybe if you didn't get an F1 or an F2 or something like that.
Yeah, I think that's a really good question. I did my elective in ENT surgery, and I did a special module in MaxVac surgery as a student. But in 5th year, I did a pediatric surgery 2 weeks special module. I found that really eye-opening. So I would try and get that if you can get a student placement in it. That's always helpful. And then foundation, it's really hard. Some trusts just don't have ped surgery, so you know that's really luck of the draw. But getting a taster week, I did a taster week in A&E, but in the ped surgery unit I'm in now, we've had 5 or 6 5th-year students come in already since they've come back in September. That have done the taster week already. I think it's really key, and it goes on your CV, and it shows you're interested, and also it will open your eyes and get you in touch with some people that work in ped surgery. When you are at core level, applying to core surgical jobs, absolutely put the jobs in pediatric surgery at the top of your list, so that hopefully you can get rotated through and you get a 6-month job in a unit, and then you really get to make some contacts. The website I mentioned, BAPS, has got loads of information about ped surgery as a career, and then the Yorkshire and Humber Deanery website is where the ST3 applications are. They've got their criteria for what they want their ped surgeons to have, so there's a really good list on there for you.
Okay, fantastic. Is manual correction safe for testicular torsion?
It's a good question. I've only seen it done once, and that was in the Belfast Children's A&E. It's safe, but you have to be extremely confident that it is done well. So that's basically twisting the testicle outside of the patient. You must be convinced that you know that it's a torsion, which way it's twisted, how far it's twisted. So it can twist 180 degrees and not be ischemic and just be a bell clappers. It could twist 270 and be ischemic, or it could twist 540. It's really hard to say, and in fact you can't, unless you can visualize that testicle, you'd have to be extremely confident. I've seen it done once, and this child was the most upset person, and then he suddenly just went and he was a 2-year-old screaming for hours. So I would put, at my level, I would need to explore it and look at that testicle. But I think some people would say it's safe, yes.
Okay, sure. Are there any pediatric specific causes of hypercalcemia, which I think you mentioned was one of the causes for sort of abdo pain?
Yes, you can get parathyroid problems But apart from that, I can't really tell you too much about it. It's very tricky. There are awful lot of kids with complex metabolic problems and endocrine problems, and they often run into issues with their electrolytes and salts. So hypercalcemia would be not common, but it is a cause. Bones, moans, stones, and groans. So it's important to always rule it out on admission for abdominal bloods, as it can explain why, and also makes people more susceptible to stones, whether it's ureteric stones or gallstones, which could be the cause of the pain too. So apart from the parathyroid and endocrine metabolic general, I don't know too many specific causes, I'm afraid.
Okay, I think that's all we've got time for today. We've just gone past five past 8. But once again, thank you so much, Sean, for a fantastic lecture. Thank you everyone for coming tonight. If you haven't filled out the feedback, just another quick plug for that. Links in the chat as well. Some thank yous coming in on the chat there as well for you, Sean. Okay, so thank you all for attending the webinar series. This is the last one. Please sign up to our mailing list and stay in touch with us on social media as well, and looking out for future things, future webinar series that we're looking to run in 2021 as well. Okay, thank you very much, guys.